this way. Lovers in the night, boats trying to ride. We don't know how to rhyme, but down we try. This way.
Okay, a little bit of Lady Gaga to get us started this evening. And I like that song better than Shallow from that movie, personally. All right, tonight we're going to cover altered mental status. And so we're going to talk about things like dizziness, syncope, seizures, strokes, and diabetes. In the PowerPoints that I sent you this morning, there's stuff in there about behavioral emergencies. We're not going to be covering that tonight. I forgot to pull those off there because that's going to be part of the homework assignment that's going to be presented for over Thanksgiving. I do have a request to put those out early, so I'm hoping to get those posted probably by Friday because I still have to figure out which ones we're doing. Alrighty, so let's do a screen share here. And I am recording, by the way. All right. All right, you guys seeing the screen you want to see?
Yes.
Yes.
And you're going to see these things like teaching tips. Understand that this is a mixture of slides I put together. So some of them are appropriate and some of them won't match what's on the slide. That's because I copy and paste slides and things like that. All right, so altered mental status. So there's different causes for somebody to be not alert. Things like, they're hypoxic, there's something wrong with their sugar levels. The brain tissue isn't getting perfused appropriately. They could have an injury, it could have infection, they could have toxins or pharmaceuticals in there, damaging things. Could have a stroke. Again, hypoxia could be due to a variety of different breathing problems if we're not getting enough oxygen. There's a mnemonic that helps us remember some of the causes for altered mental status, and we call it AEIOU tips. And I'll just run through those kind of quickly. But A stands for alcohol or acidosis. Acidosis is, remember, when our blood level, our blood pH goes down. That's called acidosis. And that causes a whole variety of different things, different organ failure issues. E stands for epilepsy or an electrolyte problem. You know, sodium chlorides, things like that are off kilter, potassium, things like that. I stands for infection. O stands for overdose or oxygen deficiency. U stands for underdose. We'll talk about that when it comes to seizures. One of the biggest reasons people have a seizure is because they're not taking their medicines correctly. T stands for tumor or trauma. I, another I, that's for insulin issues, again, a diabetic problem. Poisons, psychosis. Sometimes people pretend they have an altered mental status or they pretend to pass out. S for shock or a stroke. Okay, so AEIOU tips. So first one I want to talk about is dizziness, and it's a very common term, but it means different things to different people. Vertigo is a word we use to indicate that things are spinning around you. Okay, so that's vertigo. And a lot of people that have vertigo, it's because they have something called Meniere's disease, and that's an inner ear issue. And that causes a loss of balance and the sensation of things spinning. And they can actually fall down from this because they get so disoriented. So even though they may be mostly alert, but if they're having dizziness, that's a precursor to maybe something happening that's going to affect their mental status. So lightheadedness is a sensation you're about to pass out. And that word here, pre-syncope. So let's talk about what syncope is. Syncope, it's a brief loss of consciousness, but the people wake right back up. They pass out for whatever reason, and within seconds, maybe a minute or less, they wake up. So that's syncope, and when they have that happen, it's called a syncopal episode. Syncopal episode. It's usually very short, and they have sometimes they have a warning. They get that vertigo or they get the dizziness sensation, and sometimes they know enough to sit down before they fall down. Okay, so somebody that passes out and wakes up, we call that syncope, or they've had a syncopal episode. So a lot of different causes. They could be hypovolemic, so they don't have enough blood volume, and it might be because they're dehydrated. Maybe the red blood cells are there, but the plasma levels are not what they're there, so we're not getting good perfusion. It could be a metabolic reason, like with a diabetic problem, or something wrong with their electrolytes. They could have breathed in some chemicals or had some other environmental assault on them that made them pass out. Or it could be heart related. And anybody that has dizziness or has had a syncopal episode and they also have chest pain, that's a pretty ominous sign. That means there's something probably really, really wrong going on with their heart. If you have chest pain and you pass out, that's not good. And the other one is psychogenic, something, whether they're either faking something going on or they've had some emotional distress of some kind that made them pass out. It's the body's reaction to, say, play dead. Okay, so when the bear is running at you, you lay down and play dead. That's a psychogenic thing. Okay. So somebody that's had dizziness and syncope, again, administer oxygen if their SpO2 or their pulse ox reading is less than 94%. If any symptoms persist, they pass out again, they still remain dizzy. Again, it could be a cardiac origin to the dizziness or something like that. But if it persists, then you definitely need to call for ALS. And anybody with an altered mental status, the protocols require you to call for advanced life support. So if you get there and these things have resolved, maybe you don't need ALS. But if they're still having some residual dizziness or they feel like they're going to pass out again or something like that, then you definitely need to call for ALS if you don't have it in your own squad. Make them comfortable, position of comfort, loosen any tight clothing. Sometimes it's related to hypotension, like we said, so low blood pressure. So you're going to have to lay them down. because if their pressure is less than 100, and they're not a long distance runner, you need to lay them down and maintain their systolic blood pressure. If they did pass out and fall, you may have to treat any injuries that came from that fall. Okay? So let's talk about seizures. So again, there's electrical activity that occurs in the brain, and it's chemical electrical, okay? When that normal activity is interrupted from a variety of reasons, whether it's an injury, they've got an infection like meningitis or encephalitis, infection of the layers of the tissue around the brain, that would be meningitis, remember? And encephalitis is when you have an infection of the brain tissue itself. Or some other disease process going on. That electrical activity can become irregular and cause us to have issues. So those issues can bring about a seizure, and they could be a sudden change in sensation, behavior, or sometimes muscular movement. So a seizure is a sign. It's not a disease itself. It's a sign indicating that there's something else going on, okay? There's something else going on. They've got some sort of a medical defect or disease, or they've been injured, have a tumor, a variety of different things. So the first one we want to talk about is a seizure called tonic-clonic. And the old term for this, or the layperson's term for this, is grand mal seizure. You may have heard that. Or convulsions. So grand mal convulsions, but we call them tonic-clonic, okay? These are the most severe type of seizures that we see. And these are the ones we get called for. There are other type of seizures we're going to mention in a minute, but we rarely get called for EMS for those kind of seizures. So in somebody that's going to have a tonic-clonic seizure or grand mal seizure, they're going to go unconscious and they're going to have major muscular contractions. And there's 3 phases to a tonic-clonic seizure. The first phase, tonic, okay? Now tonic means to tighten up, okay? So what happens is when the seizure comes on, all of the muscles contract and they just tighten right up. And quite often, if you're near the person when this starts to happen, you'll hear them let out a yell. And what that is, it's the muscles around the chest that are contracting, forcing air out, and they'll go, ah! And you'll turn around and you'll see them like frozen, and then they fall over. So if you're there, when you witness this, catch them, okay? We don't want them to get hurt. And that lasts for around 30 seconds, give or take. And then we go into the muscular contraction phase, which we call clonic. And these are the violent body jerks all over the place. And this can go for a minute or two until the patient gets hypoxic enough that that activity stops. And it usually doesn't just stop. It usually slows down and eventually stops. And that's the phase that we can call, a lot of people call it convulsion. Then they go into a resting phase, and we call that post-ictal. Post-ictal. So you need to know these 3 phases: tonic, clonic, and post-ictal. The post-ictal phase is after the convulsions and contractions stop, and then they slowly will regain consciousness. This is when we can start doing something, okay? When they're tonic and clonic, about the only thing we can do is protect them, keep them from hurting themselves. But once they get in the post-ictal phases, this is when we kick in to do some EMS. Okay, and we'll talk about that in just a second. Some people,
Ron,
what's that?
Ron,
Yes.
don't let them get their hand on you and get a hold of you in that phase. It really
Because of the contractions, they could, yeah, they could break your fingers
really
off.
hurt. It really hurts.
Yep, absolutely. And you never put your fingers near their mouth. Some people are going to have usually tonic-clonic, but also some of the other types of seizures. They may get something called an aura. And that's a sensation that they get that's telling them they're about to have a seizure. And it could be a variety of different things. They could have a funky smell, or they could hear something. My stepdaughter used to have seizures until she grew out of them finally. And she would get a metallic taste in her mouth. And then she knew she was going to have a seizure. She used to carry a bite stick and put it between her teeth because she had that 5 seconds knowing she was going to have a seizure. And it's an aura isn't like 30 seconds before, it's seconds before. So it's a variety of different things. Some people see sparkling lights, things like that. There's a variety of different things that it's different for everybody, but we call those an aura. All right, so why do people have seizures? Well, if they're hypoxic, the brain's not getting enough oxygen. Okay, it's going to interfere with that chemical, electrical, pathways, and could cause seizures. Somebody could have a stroke, and we're going to talk about strokes a little bit here. But basically, we've cut off blood supply to part of the brain tissue, and then it gets all haywire. They could have a traumatic brain injury, and that could be that just occurred, and now they're having a seizure because of it. Or it could be something that they had it 2 years ago and they've been having seizures, once a week since then. Okay. They could have had some bad substances come into them, toxins, poisons. Toxins, again, are produced by pathogens. Okay, so they could have a infection going on somewhere, and those bacteria and germs, toxin, or those pathogens, when they die, release toxins. They could be hypoglycemic, so hypo low, glyce sugar, low blood sugar. Okay, so there's not enough sugar getting to the brain cells. Again, interfering with that chemical, electrical pathways. They could have a tumor. It's putting pressure on different areas of brain tissue. They could have a congenital brain defect, something they were born with. Congenital means born with. Again, they could have an infection, the encephalitis or meningitis potentially. Idiopathic. Idiopathic is a word that means we don't know. So whenever something's happening and we don't have a good understanding of why, it's considered idiopathic. Okay. And sometimes we use that for syndromes too. Some syndromes, like we don't know what's going on, but there's some connection with other things and we just haven't figured it out yet. Like sudden infant death syndrome, that sort of thing. We don't know what causes that totally. And then they could have the medical condition known as epilepsy. And the big reason people have a seizure is they have epilepsy, or they maybe have traumatic brain injury and they're non-compliant with their medications. They run out of it, they can't afford it, they just forget to take it, and then boom, they have a seizure. So what are we gonna do when somebody has a seizure? Get them on the floor, if they're not already there, get them to the lowest point you can, loosen restrictive clothing carefully. You may not have a lot of opportunity to do that. Remove any objects that may cause, patient harm. We don't banging their head on a desk or a chair, or even on the floor for that matter, if you've got something to put underneath their head. So the big thing is protecting them from injury, but do not try to restrain them. Do not try to hold them down. These convulsions and contractions are very, very forceful. And people having seizures can actually break a bone. So if you're trying to restrain somebody and hold them down, you're not going to stop the seizure by doing that. All you're going to probably do is hurt them. So let it occur, you wait till it gets done, and then we kick in. Do not attempt airway maneuvers. Everybody says, oh, they're going to swallow their tongue. Nope, physiologically not possible. Okay, they may bite their tongue. My stepdaughter, every time she had a seizure, would bite her tongue. I went to a call one time at a Pizza Hut, believe it or not. Subject was having a seizure, and they were still seizing when I got there, and we'll talk about why that's bad in a minute. But honest to God, one of the workers at the Pizza Hut had a steak knife. She was trying to jam between this lady's teeth because she was going to swallow her tongue. She was trying to open it up. And Bill and Bob might remember this, but back in the old days, we had something called an oral screw, which was like a big wing nut type looking thing and corkscrew looking thing. And we were supposed to put it between molars and twist it to open that patient's jaw during a seizure. Bad thing, bad thing. Stay away from their mouth. You'll get bit. And you're not going to help them any. Okay, once they enter that post-ictal phase, the coming out of it phase, now's when we have to watch that airway. This is the time. And these people, because there's a lot of stuff going on, because there's muscles everywhere doing stuff, they get full of phlegm. If they've cut their tongue or bit their tongue, there's going to be blood in it, and it's full. You may have to use Mr. Suction, okay, to open that airway, okay? When they come out of it, you're going to probably put them left laterally recumbent, okay? Get them on their side, let gravity help drain that stuff out, and then use Mr. Suction to clean it up. So left laterally recumbent, or that recovery position. it says if patient's cyanotic, they will be cyanotic. They will look dead when they come out of this. So again, open an airway, get them on the left laterally recumbent position. If you need to, you can do artificial ventilation, but most of the people will start breathing deeply because they're hypoxic. So the body wants to get more oxygen in. You can give them oxygen. There's nothing wrong with that. But if you need to, you can ventilate them with bag valve mask, but you probably will not have to. People don't usually die from a seizure. What happens is they do die, but it's because their airway got blocked more often than not. One of the very first seizure patients I went to was down on 2nd Street, and the poor guy, he was just walking across a dirt parking lot. It had been raining, and fate intervened, and he had a seizure and landed in a mud puddle, and he drowned. I get there, and he's basically in respiratory arrest. I'm suctioning pieces of stone out of his airway. But he ended up basically drowning in a puddle because he had a seizure. And again, when they come out and they're in this postictal phase, they're just all flaccid, okay? And they're not awake yet. So they can't protect their own airway. I had another person that we used to pick up all the time that had a seizure and suffocated in a pillow. And I had the other one I had that I remember, they had a seizure, they were sitting on the toilet, and there was a wall right next to them. And when they had the seizure, they got wedged between the toilet and the wall with their head in a flexed position, and it blocked their airway with all the secretions and everything. They suffocated. We found them dead in that position. So you don't usually die from your seizure, you die from the complications and the circumstances surrounding the seizure, okay? But we do know now, more seizures people have, actually the more long-term brain damage they can get. Because the brain doesn't like to be insulted, you know, and getting hypoxic like that. People that have a history of seizures, and not everybody's seizures are controlled by medication. Some people, even though they're on medications, and there's a lot of different medications out there, anti-seizure meds, but they still have seizures and they're used to having them. And if they're with family and they come out of it and you get there and they're alert and all that, you don't necessarily have to transport them. If they're alert and their vital signs are within normal limits, they can sign off, okay, because they're used to having these things. First time seizures, or somebody that hasn't had one in a year or two, those people need to go to find out why, okay? So if they need to go, or they still have, actually if they still have some altered mental status, that's a call for ALS too. Advanced life support, paramedics carry Versed, which is kind of like Valium. It's a benzodiazepine, it's called, and that stops seizures. So in case they were to go into another one, an ALS provider can give that medication where we can't as basic EMTs. Excuse me. Seizures last about 1 to 3 minutes, long enough with all that muscle contractions and hemming and hawing and all that stuff to get hypoxic, and they normally come out of it. There is an exception, that's febrile or fever seizures in children. I've had children that seized for 30, 40 minutes straight without stopping, because children can breathe, babies, primarily infants and toddlers, they can breathe through their seizures, where adults do not. So they can keep it up longer, okay? So if the patient is breathing adequately, go ahead and give them oxygen. They've been hypoxic, I don't care what their SpO2 is at the moment for this particular case. Go ahead and give them some oxygen until they wake up and are alert. And then treat any injuries. Again, they could have banged something on the way down to the floor. Lord knows what they were doing when the seizure occurred. If they were working in a factory somewhere, they may have gotten hurt from machinery. They could have bonked their head. They could have broken a bone during the seizure, a variety of different things. And then in many cases, you're going to transport, unless it's the people that, they have a seizure 3 times a week type of thing. One thing that is very scary and it can be life-threatening is something called status epilepticus. And what this is where they have 2 or more seizures, but they don't regain consciousness in between. They don't necessarily have to be 5 minutes, they could be 3. So if they've had a seizure, by the time we get there, they're out of it. They're out of it. So if the case of like the Pizza Hut lady I was talking about, she was still seizing when I got there. It was her second seizure, and she never woke up in between. That's serious. That's a high priority case. So that's an immediate transport to the hospital and getting ALS to get that Versed into that person, or Valium if they're carrying Valium to stop that seizure. So status epilepticus, you have to understand that. All righty. There are some other types of seizures. There's partial seizures where you may have one part of the body that's involved. We also call those focal motor. These people don't lose consciousness. Sometimes their arm will stiffen up. Sometimes it might start in their hand, and then next thing you know, their arm stiffens up and keeps going up the arm and it's moving. We call those Jacksonian. It's on the march, like Jackson's March to the Sea type of thing. So that's a partial seizure, but they don't lose consciousness. A complex partial seizure is where they lose awareness. They may exhibit odd behavior. They can be confused. Again, they're not unresponsive, but there's a definite behavioral change of some kind. And then and this one lasts for a little while. It can last for a minute or so. And then when they come out of it, they don't remember it. Okay, so that's complex partial. And then there's absence seizures. This is the one's called petit mal. And this is where they just stare off into space for like 10, 15 seconds, and then they're back with you. Okay, so that's an absence seizure. The ones that last longer than 10 seconds, and sometimes they can exhibit odd behavior, those are complex partial seizures. And then we have the fever seizures in pediatric patients. All right, any questions on seizures?
Ron, I had one question.
Yep.
So when they're having convulsions, if they don't even hit their head, can that cause like a C-spine injury at all?
Yes, if they fell on the way down, and you get there and the bystander says, yeah, he bumped his head on the desk on the way to the floor, definitely could. The nice thing is the C-spine is a pretty durable portion of the spine. It is injured more often because it's out there like the lumbar spine without other protection around it, but they're still pretty strong bones normally, unless you have a bone disease or osteoporosis or something. And you have a lot of ligaments tied there too. So normally just bonking your head is not going to break your cervical spine. It takes a little more force than that, something like a diving accident or a car accident or something like that, not just falling down. But if you get evidence of hitting something, then you're using the collar and all of that stuff, for sure. Anything else? Okay, let's move on to diabetes. Terrible, terrible, terrible disease. Insidious disease, causes all sorts of issues that are far-reaching and reaches a lot of different organ systems. So the basics: glucose. Glucose is a form of sugar. The body takes in glucose or other sugars or other carbohydrates and then converts them to glucose. And then that glucose gets put into the bloodstream so that it can be taken to the cells. So the glucose is the body's basic source of energy. So body cells require glucose, okay, in order to create their energy or do their work aerobically. Remember that word? Using oxygen, right? So in diabetes, we have a problem. So we have this other thing called insulin, and insulin is a hormone, and it's produced in beta cells in the pancreas. And insulin is kind of like a doorman, okay? Glucose molecules are large, and it's hard for them to go through cell membranes. Remember, as animals, we have cell membranes, but no cell walls. Plants have walls, we just have membranes, which are semi-permeable. Oxygen can go in and out of them, electrolytes can go in and out of them, hopefully glucose can go in them, that sort of thing. But this is a pretty big molecule, the holes aren't normally that big for that molecule to get into the normal cells. It can get into brain cells much better. But regular body cells, it's really hard for that to get in there unless we have this doorman that we call insulin. So again, it's produced in the pancreas. It sticks to receptor sites on the cells. And when that glucose molecule comes up and that cell wants it, it acts like opening the door to that cell, and then glucose can enter. And then the door gets shut, okay? We need a balance of sugar and insulin in order for everything, glucose and insulin in order for everything to work correctly. We need to have a balance. If we have too much sugar and not enough insulin, can't get into the cells, okay? So different types of diabetics. Type 1 diabetes used to be called juvenile onset diabetes. So in this case, the body's not making the insulin it should. There's a decreased production or no production of insulin. So it's not secreted out of that pancreas in the normal fashion. So therefore, there's not enough of that insulin to be circulating in the body to attach to those receptor sites on the cells to open the door to let glucose in the cell. And these people are on insulin shots, okay? Synthetic insulin, and then they take shots for that. Or they have a pump that's permanently placed in there so they can give themselves subcutaneous injections. In a type 2 diabetic, in this case, the body is producing insulin, but for whatever reason, it's not working right. It's not allowing the sugar to get into the cells as well. Some does, and actually the majority of it does in many cases. But in this case, it's there, but it's having trouble getting glucose into those cells. And these people usually are on some sort of an oral medication, anti-diabetic medication, which assists insulin in making those cells a little more porous to the glucose molecule. The type 1 diabetic is the one that we normally see most often when they have a problem. And there's two problems that we see diabetics for, two main problems. The first one is hypoglycemia, low blood sugar. And it's also been called insulin shock because the patient will look shocky, like somebody that had trauma that was in shock. They're going to have a very similar appearance, except for their mental status. And the other thing we see is hyperglycemia, or high blood sugar. And as this hyperglycemia continues, it will lead to something called diabetic ketoacidosis. $1 million word there, but we'll talk about it in just a minute. So in hypoglycemia, there's a couple reasons a diabetic can get hypoglycemic. Now, there is a syndrome called hypoglycemia, which is different than a diabetic hypoglycemia. People that have hypoglycemia that are not diabetics have a problem where their body takes the sugar that they eat, their carbohydrates or whatever, and dumps it into the bloodstream really quick. And then, so a bunch of it goes into the cells really quick. And then all of a sudden the blood sugar falls off and they become hypoglycemic. But they don't have the same affect or presentation that a diabetic hypoglycemic gets. These are the people that have, you may have known somebody that had a glucose tolerance test where they had to drink the Coke syrup stuff, and every hour they had to have their blood sugar taken, that sort of thing, to see how rapid that drop off of their blood sugar was. Those people get diet controlled. So a diabetic could take too much insulin, and too much insulin means too much sugar is going into the cells out of the bloodstream, and the blood glucose level drops and they get hypoglycemic. Maybe they took their insulin but haven't eaten. So they don't have the carbohydrates to process to turn into glucose to go to the cells. Or maybe they've eaten and they've taken their insulin, but then they overdo it. They overexercise or something like that, and they're using up a lot of sugars and that insulin to get sugars into the cells. And so their blood sugar falls off. Or they took their insulin, but they ate, but then they threw it up. They didn't replace it or couldn't replace it because they were sick. So those are common causes for hypoglycemia. The nice thing is for us, it's a very rapid onset. They were fine 45 minutes ago. Now all of a sudden there's something going on, okay? And they could present with abnormal behavior. Some of them will get violent. They may act like they're drunk. Or you could be like Bill's brother-in-law. I used to work with him, and he was a diabetic. He's actually had a pancreas transplant. He was a medic, and we'd be working with him, we'd be sitting at the table waiting for a call or whatever, and all of a sudden he would just sit there and start smiling. That's all he did. And we were like, Greg, we're going to get you a candy bar, you know, because he needed sugar. So they may, like I said, they may act drunk. They could start saying inappropriate things. The violent ones are the problem ones. They're hard to treat. And I got a quick story about that one that Bill will appreciate. But I got a call for a diabetic problem in a car at 7-Eleven at 2nd and Buffalo Street. And this was several years ago. And I get there, and there's already a couple of Jamestown firefighters in the car trying to hold this guy down because he's just a flailing. He's going all over the place and going crazy. So I knew I needed to start an IV on him and give him sugar right into his vein, because there's no way to give him in their mouth. They can't protect their airway at that point. So I get this guy's arm, and I roll his sleeve up. I take his watch off, and I put my tourniquet on to raise the vein up, make it easier to put a needle in. And I start patting his hand, because that's another thing we do to help raise the vein up. And one of the firefighters says, "Hey, that's my hand." You think he would have told me when I took his watch off? But with all the thrashing around and all the arms like this, you know, so they can be a problem to treat. And again, it's not their fault. They're not doing it on purpose. They're having this metabolic problem that's causing their altered mental status. Okay. They also are going to look pale and diaphoretic. Remember, diaphoretic means sweaty. And they're going to be tachycardic. So this is pale, cool, clammy tachycardia, similar to hypovolemic shock. Okay. If the blood sugar drops too low, they could have seizures. The normal blood glucose range is somewhere, you know, depends on what book you look to or what doctor you listen to, but right about now, it's basically, you know, 80 to 100. Some people will say, well, 100, you're pre-diabetes. Well, I don't know. But so these people, once you become an EMT, again, you can take a credentialing class. It's very short, to learn how to do blood glucose monitoring. It drives me nuts that we have to have a special class for that, because an 80-year-old guy with one leg and blind in one eye can go buy a glucose monitor in a drugstore and do it. But we can't, because we're licensed professionals. So it's real simple, but it's not part of the course because it's not mandated by New York State for you to do that on an ambulance. So that's an add-on. So if you were to take their blood sugar, if you were credentialed to do that, or the family told you what the glucose monitor said, if it was 60 or less and they can protect their airway, we can give them sugar. If it says high, then that's the other problem. That's the hyperglycemia. These people could, if their blood sugar drops low enough, could have seizures. So scene safety, again, they could get violent. Always ABCs, no matter what we do. We can give them, we don't normally give anybody anything by mouth. Normally don't do that, okay? The last thing most patients need is something in their stomach, especially if they're going to the hospital, they may end up having to have surgery, okay? Anesthesiologists don't like that. But this is a case where we can. If it's mild enough and they exhibit some of the symptoms of hypoglycemia that we just talked about, we can give them something to eat or drink, okay? Something that has sugar in it. Orange juice, maybe with some sugar packets added. Milk with sugar packets added. A non-diet cola type of thing. A sandwich, okay? And you can have their blood sugar will raise after about 15, 20 minutes, and they may not have to go to the hospital. Because if they're diabetic, they're aware of these situations and they know how to monitor it in most cases. Some of them are non-compliant, just like seizure patients that don't take their meds, but most people are. We also carry, remember, oral glucose on the ambulance. And those are tubes, look like toothpaste tubes, small toothpaste tubes. They're usually cherry flavored. And there's 25 grams of dextrose in them, which is a form of sugar. And so we can put that on a tongue blade or put, in between the cheek and gums slowly. We don't put the whole tube in at once because then, it's a gel. So they could, get gooped up there and have an airway issue. But if they're not protecting their own airway, then we don't do anything by mouth. At that point, we need to call for advanced life support so they can start an IV and run sugar in. So if they're at any risk for aspiration, we give them nothing by mouth. Again, anybody with altered level of consciousness or mental status is supposed to have ALS called, okay? And these guys can start an IV and then they run a sugar solution into them. And again, if you can, you get credentialed, check their blood sugar and see what it is. Less than 60, they need sugar, okay? If they're alert enough, give it to them orally. If not, ALS is gonna have to start an IV. In either case, you're gonna have to be transported, more than likely, unless you totally wake them up. All right, hyperglycemia. So why do we have too much sugar in our bloodstream? Well, maybe we don't have enough insulin. There's not enough of those doormen to allow those sugar molecules to get into the cells. So those sugar molecules just stay in the bloodstream and start building up and building up. They could have an infection going on that's interfering with the function of insulin. Stress can sometimes cause issues. Maybe they're eating too much but not taking enough insulin. Again, these will be type 1 diabetics. Joe Blow person doesn't get hyperglycemic unless somebody's been trying to do it to them on purpose somehow. So they've been eating too much, or they've had too much alcohol, okay, over a period of time. New onset, this is how we find out people are diabetic. They get hyperglycemia. So this is the 13-year-old girl that's been sick for a week and she's feverish and she's all curled up in the fetal position and she's peeing all the time. She's always thirsty. She's always hungry, that sort of thing. They take her blood sugar and it's way out of whack. It might just say high on the meter, okay? Oops, you're a type 1 diabetic. We just discovered it. So opposed to hypoglycemia, which onset is half an hour, maybe an hour as it comes to be, this takes days. This takes days. They're always thirsty and they're feeling hungry. Now, you might think, well, geez, all that sugar in their bloodstream, they shouldn't feel hunger. You gotta remember, that sugar's not getting in the cells. It's staying in the bloodstream. So it's not doing what it's supposed to do. So they're gonna feel hungry. The cells want energy. And they're thirsty because we have increased urination, polyuria. So what happens is the body, because there's too many glucose molecules in the bloodstream, the body still wants to get rid of them because there's too many of them there. Tries to maintain that homeostasis, right? So we pee those out. And of course, if we're peeing out molecules, just like sodium and chloride, we can't pee out salt cubes, okay? We can't pee out sugar cubes. We gotta take water with it. And so because there's so much sugar, they're peeing a lot. So they're peeing all the time. Consequently, they're always thirsty, okay? Quite often they'll have nausea or abdominal pain. Quite often they will have a fever, especially once we're into the many, many days going down the road of this. Okay, they get dehydrated because again, they're peeing a lot, okay? And they're not, even though they're thirsty, they're probably still not taking in enough water because they're sick, they're laying in bed. They're not getting up and doing stuff, they're just getting sicker. Because the glucose isn't getting into the cells, we can't do the aerobic metabolism as well, right? So what was the opposite of that? Anaerobic metabolism. And again, that's when the body still wants to make energy, still wants to do its work, the cells. So instead of using oxygen and glucose to create ATP and make energy, the body starts breaking down proteins and fats. And the byproducts of anaerobic metabolism are acids and ketones. So those waste products get put into the bloodstream. We might get acidosis, okay, like we mentioned earlier, and we get ketotic. The body wants to get rid of these things. And one of the ways it can get rid of them is through respirations. Remember we said way back when that respirations, the respiratory system also is involved with excretion. And I mentioned the person that had a breathalyzer test, you know, the byproducts of alcohol metabolism is read into a breathalyzer. Well, here, because we're so acidic, our blood is, the body tries to get rid of those acids by getting rid of carbon dioxide, because carbon dioxide is primarily dissolved in the plasma as a weak acid. So these people could exhibit something we call Kussmaul's respirations, and this is rapid and deep breaths. Now, normally the faster we breathe, the shallower we breathe. In this case, because the body's going into metabolic chaos, they're breathing fast and deep. So it's like they're in a 100-yard dash, but they don't stop. They never catch up. Those are called Kussmaul respirations. It's trying to get rid of the byproducts of anaerobic metabolism, ketones and acids. Consequently, these people will have, because of the being ketotic or having a lot of ketones present, and ketones are like acetone, which is nail polish remover. Their breath will actually smell a little like nail polish remover, or sometimes it's a fruity odor. These people are going to get sick, and they're going to have the worse they get. It's going to go into this thing called diabetic ketoacidosis. We call it DKA. So they're going to have a profoundly altered mental status. Because of dehydration, they're going to have some signs and symptoms of shock, but the difference is they may be feverish instead of clammy. They're going to have that rapid breathing. They're going to have that acetone or fruity odor on their breath. And these people are in trouble. These people can have blood sugars of like 700, 800, 900 instead of the normal 100. I actually had a kid one time, his blood sugar was like 1800. That's really not compatible with life. They had to put him immediately on a dialysis machine to try to get that stuff out of there. So what we're going to do for hyperglycemia and diabetic ketoacidosis, obviously ABCs, position and comfort. A lot of the patients I've gotten that were hyperglycemic that weren't quite in DKA yet, they were left on their side, curled up like in a fetal position, feverish, belly pain, just really sick looking. Call for advanced life support, especially if their blood sugar is really, really high, because even though there's not an awful lot that we can do, at least the medic can start an IV and start running fluid in there to try to dilute some of that and add some more fluid because these people are dehydrated. Excuse me. What they really need is insulin, and that has to be done at the hospital. Medics don't give insulin. They can transport a patient that already has it running an IV drip, but they can't like give somebody an insulin shot. Again, if you're credentialed, get a blood glucose level and see if it reads high, okay, or if it reads something like 300 or something like that. Again, anything more than 200 is start to get concerned, okay? If you're hyperglycemic and you've been in the hospital, they won't even think about letting you out of the hospital until your blood sugar gets down to at least 200, because they know then they've got it starting to get under control. Again, if their SpO2 is less than 94, they can get oxygen, and they definitely need to go to the hospital, okay? So the real quick, again, comparison, hypoglycemia, the low blood sugar, it's a rapid onset. That's usually your first indicator. They're going to have altered mental status, which mimics intoxication. They could get combative, and they have that pale, cool, clammy skin. And again, if it's really low, they could have a seizure. For hyperglycemia, it's days, maybe even a week or longer that they've been sick, okay? They usually have warm, red, dry skin because they're dehydrated. They may have that fruity or acetone breath, and they just get sicker and sicker as each day goes by. And then once it gets too high, and then that's where the altered mental status, which is our topic tonight, comes into play for the hyperglycemic patient. Hypoglycemic, They have altered mental status in less than an hour, and hyperglycemia takes days. And again, they're peeing a lot, that's polyuria, they're thirsty, and they're hungry. So terrible, terrible disease, does a lot of things, but these are the reasons we get called for EMS. There's a lot of other things that diabetes mellitus does. Diabetes mellitus is the official full name, I guess. Mellitus is a word which means honey, because of their fruity breath, I guess, I don't know. But it causes heart disease, it causes artery disease, like coronary artery disease. Especially in the periphery, like in their feet and their ankles, where there's a lot of stasis or blood that's not moving very quickly. So these people end up having toes cut off or feet cut off, as you know, there's massive infections because there's not good blood circulation because of the damage that diabetes has done to their blood vessels. They're more prone to strokes and things like that as well. So it's really nasty, nasty disease. Unfortunately, there's nothing to prevent you from getting it. All right, another thing I want to talk about quickly, only because the book really talks about it, but is sepsis. It's a big buzz thing nowadays in healthcare. And sepsis is a severe infection that's usually progressing throughout the body or through the bloodstream. When we get an infection, it's usually a localized thing. The blood vessels in that area dilate, the capillaries become permeable so that white blood cells can go attack the infection, and they can leak some fluid into that area to try to, you know, dilute the toxins and the pathogens that are there and things like that. And that's a normal body response to fight infection. The problem with sepsis is it gets spread to the whole body for some reason. Whether that's because the pathogens spread through the bloodstream to other organs or whatever. But these people get really, really sick, and quite often this can be fatal in the worst cases. So the more pathogens we have, the more toxins get released as they get broken down by our white blood cells and other things, and that starts affecting other organ systems. So sepsis is another nasty, nasty thing. So consider sepsis as a really big, bad infection, okay? So when they get septic, the condition is known as sepsis. We call them septic when we see them. They're gonna have altered mental status. They're gonna have tachycardia. They're gonna be breathing fast. That's tachypnea, tachygympnea. They're gonna be hypotensive. Sepsis is a form of shock. It's septic shock, okay? So they're gonna be hypotensive, which means they're not perfusing well. Whole thing of shock is altered perfusion, right? Quite often they're gonna have a fever, more often than not. Okay, not a lot we can do except to recognize it, be suspicious, have a high index of suspicion, we call it. So if they've had an infection and now they've got a fever, you know, it's 104, and I don't feel good all over, and geez, your blood pressure's low, sir. Geez, your heart rate's really fast. You know, be suspicious that this is somebody that's septic or going into septic shock. And that would be a thing to alert the hospital on the radio before you get there. If they have any altered mental status at all, again, put them in that recovery position. And again, every altered mental status patient gets a call for ALS. Again, oxygen, their SpO2 is below 94 and go to the hospital. All right, so that's sepsis or septic shock. All right, another form of altered mental status is stroke. Very common, a big buzz thing nowadays too. So again, it's a death or injury of brain tissue from oxygen deprivation. And what causes it? Blockage of an artery supplying blood to part of the brain. Sound familiar? Like the heart, right? It could also be from a ruptured blood vessel in the brain. We don't see ruptured blood vessels in the heart as much. We do, but not very often. But this is analogous. It's the same thing. It's just happening in a different organ. It's happening in the brain instead of the heart. So it's that artery disease, right? And some people actually call strokes brain attacks because it is basically the same thing, okay? So again, all that process of atherosclerosis, building up a plaque on the inside of the arteries, could cause a thrombus, a clot in that spot, or had a blood clot somewhere and it broke off and became an embolism and got wedged in a smaller artery in the brain, that sort of thing. That atherosclerosis, the laying down of plaque, could have caused the inside layer of the artery to rupture, which is then going to cause that aneurysm, the ballooning out, which then ruptures. Variety of bad things that happen. That could happen. 80% of strokes, true strokes, are blocked arteries. The other 20% are a ruptured blood vessel or something that we don't get into it in EMS, but it's called a AVM, or arterial venous malformation, that ruptures. But that's a whole other thing. It's still a ruptured vessel. So some of the symptoms, and not everybody has all of these. Some people only have one of these, okay? They could have a sudden confusion. They could have that dizziness, or they could have had a syncopal episode. They may have weakness or paralysis on one side of the body. Unlike a spinal cord injury, it's going to be bilateral. If it's in the brain, it's on one side of the body. They could lose control of their bowel or bladder. They may have vision impairment. They usually have high blood pressure because that's the main contributing factor, one of the main contributing factors. Diabetes is another one. They may have difficult respiration, so they could be snoring because the stroke may have affected the muscles controlling the throat and the tongue. So that tongue gets flaccid in there. Again, they can't swallow it, but it can block that airway. They could get sick to their stomach. They could throw up. They may have a seizure. They could have unequal pupils. Sometimes they have a headache. Not everybody does. They could also lose vision in one eye. And they could go unconscious. And if they're unconscious and the family was telling you they were having stroke-like symptoms before they went unconscious, that's a really bad sign because strokes normally don't go unconscious unless it's really, really bad. So we have a condition, excuse me, that mimics a stroke in many ways. And that's something called a transient ischemia attack. Now remember ischemia, the word from cardiology, which means a lack of oxygen in tissues, preparing for the tissues that are going to eventually die if that continues. So sometimes they have the signs and symptoms of a stroke, but those signs and symptoms go away in less than 24 hours. Sometimes they go away in 10 minutes. We call those a TIA, transient ischemia attack. So it could be a small clot, or sometimes it's an artery that, for whatever reason, spasms, that temporarily blocks circulation to part of the brain. It causes those stroke-like symptoms, but the symptoms resolve when the spasm stops or the clot eventually gets broken up. So the typical case where I've had these, you get a call, grandma was at the dinner table, and all of a sudden grandma went limp and couldn't move her right arm. And everybody says, oh my God, grandma's having a stroke, and they call. I get there and grandma says, I'm not fine, I'm not going anywhere. Okay, her symptoms resolved. And we all know grandmas are stubborn, right? And they're very, very hard to convince. So that's the common thing. Sometimes they do last almost 24 hours and then they go away. And then I call that a speed bump on the road of life. You got lucky. You better start taking care of yourself. Take care of that blood pressure. Do whatever you have to do to decrease your cholesterol and triglycerides and things like that. You got lucky. Speed bump. All right. So complete resolution is usually within 24 hours. And again, a lot of the cases I've seen, they were resolving in front of me or before I even got there. Okay. But you do need to know what a TIA is, transient ischemic attack. So assessment for stroke or people with stroke-like symptoms, we're going to have you do something called the Cincinnati Pre-Hospital Stroke Scale, which is basically on every billboard around that talks about stroke, right? It's the same thing. So you're going to assess the patient for slurred speech, ask them to repeat a short sentence and see if it's clear, see if it's slurred. You're going to ask them to smile for you and see if one side's down, the facial droop. Then you're going to have them hold their arms out, usually palms up, and say, hold your arms up, and then let go of them and see if one goes down. And sometimes they can't even hold it up at all. They're flaccid, and that's pretty obvious. If any one of these things is positive, the stats say that's a 70% chance of them having a real stroke. Okay, that person then needs to be treated for stroke, for sure. So patient care, obviously ABCs as always, because again, if they have some paralysis in their throat muscles and their tongue and things like that, they may have airway issues, okay? It's really important to get credentialed to check a glucose on these people because hypoglycemics can mimic a stroke. Some of their symptoms can mimic stroke. We've got some confusion, maybe some irrational behavior type of thing going on. I remember got called, I was flying in the helicopter, and I got called to a scene for a stroke because they wanted the patient taken to what's called a stroke center. And we get there, and they hadn't taken the blood glucose, so I took it, and blood glucose was 30. Gave them sugar, woke right up, no deficits, nothing. They were hypoglycemic, they weren't having a stroke. So we didn't fly them. So it's important to check glucose or have somebody check it if at all possible. Again, the normal thing with the oxygen, less than 94. If you suspect a stroke, and it's really important to know when the onset of symptoms were, when they were last seen normal, is what we call it, last seen normal. So if they're a wake-up stroke, we call it, they were fine when they went to bed, but they woke up and they have stroke symptoms, then they're outside a window, a time window. But if they're at the dinner table and the symptoms, you know, by the time you get there are only 15, 20 minutes old, they're a candidate for a stroke center, okay? Actually, our window is 3.5 hours. So the nice thing is, UPMC Chautauqua is considered a stroke center. So if you're in the local Southern County area, you can go there. Technically, if you're up in the northwest corner of the county, you probably are supposed to go to Erie. Or if you're in the northwest corner, you should go to Buffalo, like South Buffalo Mercy or Miller Gates Vascular at Buff General. But if there's a long way to go wherever you practice to get to a stroke center, you can just, consider calling for a helicopter. Again, any altered level of consciousness, they get ALS. And whatever hospital you take them to, they really got to have a CAT scan, computerized tomography, CT scan, CAT scan at a minimum. Because the first thing they're going to do is take that. And actually, when they bring a stroke patient in, they take them right to CAT scan. It's the first thing they do. They don't take them in the emergency room. They take them right to CAT scan because it's a beat the clock game. Okay, it's a beat the clock game. So they'll do a CAT scan of the head, and if they don't see a bleed, then it's one of those blocked blood vessel thrombolytic stroke. Okay, or thrombotic stroke. And they can get something called a thrombolytic. A thrombolytic is a medication to dissolve a clot, okay? There's amazing things that they can do nowadays to help stroke patients. They can actually go in the major stroke centers like at Millard Fillmore Gates, or Gates Vascular at Buff General, where they can actually snake a catheter in and suck the clot out. And they come back with 90, 95%, everything okay. But they, it's a time sensitive thing. So the first thing that gets done is they get a CAT scan. All right. So that means in order to go right to CAT scan, you got to tell the hospital you're coming with a possible stroke patient. Okay. We call that a stroke alert. All righty. So that's it for stroke. So that's it for altered mental status. Behavioral, and as I mentioned before, the psychiatric and behavioral stuff is good. It's part of the homework. So I took it out of this presentation. One thing I do want to do is go through a couple of state protocols for these things we just talked about, and then we'll be done. So I got to go to a different screen. Okay. All right, here's the generic altered mental status protocol. This is the state protocol. Remember, I hope you guys went in to look at the protocols early on. I told you to bookmark the page, that sort of thing. There's a lot of stuff in here, and there's a lot of usually test questions that are based on what's in the protocols. Our cookbook. So this is also includes hypoglycemia, and anybody with an altered mental status isn't specific to something else. And as you can see up here, even they even treat behavioral emergencies different than altered mental status, which is why I took it out of this presentation. And there's also a separate one for narcotic overdoses, which is definitely altered mental status because they're barely breathing and totally unconscious. So the normal stuff, airway management, check pupils if they're constricted, again, pinpoint, more than constricted, pinpoint, then suspect an opioid overdose and follow that protocol. If you're credentialed, it says if equipped and safe, right? Then check blood glucose. If it's below 60 and the patient can self-administer or swallow appropriately, then you can give them up to, it says 24, but the tubes come as 25 grams, so you don't get all 25 out of the tube is what it amounts to, of oral glucose or some other carbohydrate source such as a non-diet soda, fruit juice, a sandwich, things like that. If they are not able to swallow appropriately, then you're going to transport and call for an ALS intercept. Okay. And then ongoing assessment like everybody else. Okay. Pretty simple there. So that's a syncope, that's hypoglycemia, any other nondescript altered mental status. I think what I'll do is I will pull up the opioid one just for giggles, because I don't think we showed you that one. You are allowed to administer Narcan, okay? Again, for suspected opioid overdose and hypoventilation. So just because they said, I shot up with heroin doesn't mean they get Narcan. They have to be hypoventilating, which means barely breathing, okay? Watch these people, because if once you give it, sometimes they wake up and they're not happy because you just ruined their buzz. Normal stuff, ABCs, airway management, check the glucose, blah, 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 whatever. Then you can administer Narcan or naloxone. This protocol says 2 milligrams, so 1 milligram per nostril. So basically, it's in a Bristol eject. You squirt half of it into one nostril and the other half in the other nostril. Make sure you don't have a nasopharyngeal airway in. If you do, pull it back out, squirt it, and then put it back in. Because if you have the nasopharyngeal airways in there, the medicine can't be absorbed. A lot of the Narcan that is being supplied nowadays, because of all the extra stuff that's mixed with it, like fentanyl or carfentanil, a lot of that is 4 milligrams now. So you're going to give 2 milligrams in each side. Again, it's a liquid. Some of them are a really neat little white thing with a plunger. You just squirt half on one side and half on the other, okay? Yeah, it talks about the 4 milligram. Actually, it does talk about down here and other considerations. You can repeat it in 5 minutes. What we're seeing in the real world, because they train, friends and family to give Narcan now. And they're told, wait 5 minutes, it takes time to kick in. So what's happening is 1 minute goes by and they're going, oh my God, they're not breathing well. They're still not breathing well. And they give them some more. There's calls we've gone to where they've given them 6 doses, and it doesn't take me in town, it doesn't take my people 10 minutes to get there. So, they're giving it way too soon and they're wasting it. Okay. We see that with police officers too. They're giving it too quickly. It's called time inflation. They think more time's gone by than actually has. Okay. So anyway, that's the narcotic overdose protocol. Okay. So again, repeat in 5 minutes, give it a chance to work, bag them. You're going to be bagging them, right? Because they're hypoventilating. They're probably breathing 10 times a minute or less, and they're not responding. Okay. Let's pull up the seizure one. Seizures. All right. EMT level. Again, airway management, oxygen therapy, suction is needed, right? We're talking about Mr. Suction. Position the patient on their side if they have been vomiting or they've got a lot of secretions. I remember having a kid that was having a fever, probably it was a febrile seizure. I've been seizing for a while, and then I pull up, and the dad's standing out the road holding this kid, and he's seizing. He's like a 2-year-old, and so I grab him and I look in his mouth, and I could see all this fluid. So I tipped him upside down. I'm standing. I just tipped him upside down. And it was so thick, it went all the way to the ground before it broke, before the spit broke. That's how thick some of that stuff can get in their airway. So it's really important to use positioning, let gravity help you, and then follow it up with Mr. Suction if you need to, okay? When they're actively seizing, don't do anything with their mouth, okay? Once they're in the post-ictal phase, then you can put an airway in, okay? But again, if you do left laterally recumbent, which is face down, head back, okay? Face down, so the drool comes out, head back, so the airway stays open. You may not need to use an airway adjunct because they're slowly coming out of it. But if they're not, or they have snoring respirations, which they could, I've seen that several times, sure, drop an airway in. As soon as they start to gag, pull it out, okay? Or use a nasopharyngeal airway. All right, so protect the patient from harm is a big thing. Do not restrain, okay? Check their blood glucose too, because that could be the cause of the seizure, being hypoglycemic. All right, and monitor their breathing. So that's the seizure protocol. Last one is stroke. All right, so again, ABCs, airway management, glucose level, determined last known well. Okay, the exact time the patient was last seen in his or her usual state of health, okay? Then EMTs, continuing down here, whoops. Can do the Cincinnati stroke scale in all 3 areas, okay? Why does it keep doing that on me? Fat fingered syndrome. Okay. So last known well. Again, do your neurological exam, which we're going to call Cincinnati stroke scale, along with your other, all the sample and OPQRST type questions and things like that. If time from last known well or time of symptom onset to estimated arrival in the ED will be less than 3.5 hours, you're going to go to a New York State designated stroke center. Okay. Or you could call medical control to go somewhere else. Notify the destination hospital. That's about all we can do, okay? Airway management, ABCs, okay? Check their glucose if you're credentialed to do so, and get them to the right place and notify them. Do that stroke alert, okay? When a hospital receives a stroke alert, and they're a stroke center, that they kick in the stroke team. And that's the technician that does the CAT scan, the radiologist that's gonna read it, the attending physician in the ER, a variety of different people, okay? And then to see if they can give one of those clot busting drugs, like it's TPA or Retivase or something like that. You may have heard those terms. They had certain words they want you to use, but it doesn't matter. It's not important. It's not like, assessing mental status, you don't have to ask them who the president is, just start talking to them, okay? See if they're appropriate. But it says, short sentence, look for the smile, for facial droop, close your eyes, hold your arms out if they can. Any questions on the stuff we covered tonight? Anybody? Nothing? Okay. All right, so that's it. I guess we went, just about an hour and 15 minutes. So again, tomorrow night is more practice night. I may be able to get up at least maybe a couple of the homework assignments that were set for over Thanksgiving, that still are set for over Thanksgiving. So if I have time tomorrow, I will work on that. If not, it'll be Friday. I will post this to YouTube tomorrow because again, it takes a while for it to process on my computer. So I just leave when this is done. And I think, as I look at my notes, I think that's all I have for tonight, unless somebody has something. Nope. Okie doke. I did record it. Nobody had to remind me this time. So I will go ahead and stop the recording and we'll see you all tomorrow night.
Thank you.
Thanks, Ron.
You betcha.
Thanks.
Thanks, Ron.
Thank
See you
you.
later.
Bye.
All right, we'll see you.